we can go ahead and get started. Welcome, everybody. Thanks again for joining us today for Connecting Conversations. My name is Sarah Harlan. I'm the Partnerships Team Lead for the Knowledge Success Project at Johns Hopkins Center for Communication Programs, and I will be monitoring the webinar, moderating the webinar today. It's a little early where we are in the US. Knowledge Success is really excited to be partnering with FP 2020 on this webinar series. And this is our second session in this series. If you missed the first session, you can watch the webinar recording and get up to speed. That recording is posted on the FP 2020 YouTube site. And we also published a blog post summary of that discussion. And we can make sure you all have a link to that. So we'll get started with introductions and housekeeping while some other folks join us. And please continue to write in the chat box who you are, where you're calling from, and respond to the poll questions that you see on the screen. This webinar will last for approximately an hour. We will have a short presentation followed by an open question and answer session. This webinar is being simultaneously interpreted into French, and it's being recorded in both English and French. The webinar recording will be available in the coming days. You should have received information about French interpretation via email. So if you'd like to listen in French, please just click on the bottom of the screen where you see interpretation. And if you need French, click on that and it will take you to the French channel. Participants will be muted throughout the duration of the session, but if you have questions for the speaker, please type them in the chat box as you follow along, and we'll be collecting them for the question and answer period following the presentation. And my Knowledge Success and FP 2020 colleagues will be monitoring the chat box, and we'll get to as many questions as time allows. So just a little bit about this Connecting Conversation series. In case you missed our first session, Connecting Conversations is a series of discussions on adolescent and youth reproductive health. It's hosted by FP 2020 and Knowledge Success. And over the next year or so, we will be co-hosting these sessions about every 2 weeks on a variety of topics. And this is not your traditional webinar series. We're using a more conversational style and encouraging open dialogue and allowing plenty of time for questions. So we guarantee you will be coming back for more. This series will be divided into 5 modules. Our first module started 2 weeks ago on July 15th, and it's running through September 9th. And this first module focuses on a foundational understanding of adolescent development and health. So we are setting the stage and offering a framework for understanding adolescent and youth reproductive health and implementing stronger programs with and for young people. The first session was on the transformative power of adolescence as a life stage, and today's session will build on that. Our topic today is a historical overview of adolescent and youth reproductive health. So now with that, I'm pleased to introduce you to our speaker, Jane Ferguson. Jane has worked at the cutting edge of developments in the field of adolescent health for over 30 years. While working at the World Health Organization in Geneva. I should say had worked. She's no longer at the WHO. During this time, she has worked on policy, technical guidelines, research agendas, and program support tools, focusing on a variety of issues, including reproductive health, HIV, and adolescent girls. She's provided technical support to many countries, including many countries in Africa and Asia, assisting in the development of strategies and programs, capacity development, and monitoring frameworks to improve adolescents' access to and use of health services, most often using HIV and reproductive health as an entry point. She's also worked with the London School of Hygiene and Tropical Medicine, based at the Africa Health Research Institute in rural KwaZulu-Natal, South Africa. And she's now an independent consultant on adolescent health, predominantly with country-focused assignments. And she co-chairs Global Action for Measurement of Adolescent Health. So we're really excited to welcome Jane as our expert today. So with that, I will hand it over to you for a short presentation.
Hello all, I hope you can hear me. Bonjour les collègues de pays francophones. Je vais parler principalement en anglais. If we could go to the end of this slide, it's up at the top on the right-hand corner. It says expand all. Right, there we go. Okay, so I'm really pleased to have been asked to provide some of you with the rich history of adolescent health over the past 55 years. Oh, it takes a long time to get to where we are today. It's good for us to acknowledge that. We're still facing challenges, but where is the country now that doesn't recognize the importance of the health and development of adolescents? I hope to demonstrate how adolescent sexual and reproductive health has been absolutely integral to the attention to adolescent health. One of the reasons I think is because of the universality of pubertal development as a central feature of adolescence. And that's picking up from some of the things I'm sure that Susan talked about last week. And that pubertal development engenders both the promise of adolescence for new generations, new ideas, new societies, but also fears. And that's what we are kind of going through the entire time. I'll feature the technical reports and organizational commitments at the global level, which is not to deny what's been going on at a regional events and country events, of course, but time constraints today prevail. And just to say that WHO technical reports are often the product of very high level expert committees or study groups and the like. So they have special status. Okay, so the first technical report rather of WHO on adolescence was in 1965, and it was on the health problems of adolescents. Some key things in terms of adolescent sexual and reproductive health was that it spoke about the training needed for health workers to address the needs of adolescents, and it talked about the research needs in terms of looking at their growth and development, and also the hazards of early pregnancy. It wasn't until 1975 that the first, so 10 years later, the first technical report on pregnancy and abortion in adolescence was held. So that's interesting, pregnancy and abortion. One of the participants in this meeting was Dr. Murray Williams in Australia, who went on to be the president of the International Association of Adolescent Health in 1987, which goes on today. Take a look at their IAH, at their website. So this report, though, notably questioned the extent of choice and constraint of adolescents in their decision-making about sexual matters. And in addition, they also they talked about the need for research into what kind of training in sexuality education those who were family life educators were getting, what was available to them. Moving another decade to 1985, well, that was the first International Youth Year, as you say, and a WHO technical report was prepared as an input to that, as well as background to the WHO resolution on maturity before childbearing, which was important. This report, notably, urged that young people be considered as a resource rather than a problem, and also declared that it was only with intersectoral action was that the social, economic, political, and cultural conditions which determine the health of adolescents could be addressed. So the context was on the agenda. In 1989, there was a crucial statement on, a joint statement on the reproductive health of adolescents, joint with UNFPA, UNICEF, and WHO. This statement talked about the fact that there was a real lack of effective policies and programs in countries, and that there was also the failure to involve young people. And the strategies that it laid out in this document could only be accomplished through joint and complementary action by the three organizations. It should be noted too that at that time, UNFPA in fact funded the technical activities of WHO in adolescent sexual and reproductive health. And that partnership was still is a very important partnership. The other thing that happened in 1989 was at the World Health Assembly, they organized 3 days of technical discussions, during which 10 working groups were co-chaired by ministers of health and young people from a variety of countries. There was a whole raft of very notable people that participated in those technical discussions. Olukoya Ransom-Kuti from Nigeria, Bob Blum, Jane Hughes, Dick Jesser from the United States, Anna Millie Monroy from Mexico, Pernilla Senanayake from Sri Lanka, Abdullah Sar from Senegal, Shiv Kari from India, and our own Herb Friedman. And of course, there were many, many more. But these were some of the early, I wanted to feature some of the early, really founding fathers and mothers of adolescent sexual and reproductive health. I wanted to name them. In 1990, of course, that saw the ratification of the Convention on Rights of the Child. And the importance of that to adolescents was first the emphasis in the wording of rights, and also that it took children up to the age of 18. And they also asserted, for adolescents in particular, they asserted the evolving capacity of children. And that is an enduring notion of development, both child development and adolescent development. And then, of course, in the 90s, there was the 1994 ICPD. And it was at the ICPD that WHO first started talking about sexual and reproductive health. And although this language wasn't reflected in the program of action, what was reflected, 1990, 1994, what was reflected in terms of adolescents was the importance of addressing HIV among adolescents, particularly in terms of prevention, and explicitly cited the need for sexuality education and adolescent involvement in program design. In 1995, too, I also wanted to mention that something that's not on this timeline was that the WHO HIV program did a series of systematic reviews on sexuality education and the impact of it, and put out a public statement which said that sexuality education did not lead to early or increased sexual activity among young people, even when contraceptions were made available. So that was a really important advocacy statement, and we know that this is still an ongoing challenge. Okay, in 1995, right after that, again, there was a joint study group, but this one focused on programming for adolescent health and development. And this set out a common agenda that had recommendations for countries, for international organizations, and also at regional level. And it also said to countries that they need to aim on both healthy development as well as issues of preventing and responding to health programs. There was the presentation of key intervention areas for adolescent health, including, most importantly, it talked about the report, the safe and supportive environment, which include interventions, laws and policies, mass media, among the community and in parents, but in particular those things that dealt with social norms and in particular gender equality, but also the importance of information skills and access to health services. And then moving right along, of course, there was the year 2000 and the Millennium Development Goals, and that really stepped up the pace through the inclusion of adolescent targeted indicators and targets. These related to HIV and maternal health, but this gave the adolescent sexual and reproductive health a clearly defined place in the global public health agenda, which it didn't have before. These targets and indicators were subsequently then made part of commitments at the UN General Assembly Special Session on HIV and the UN General Assembly Special Session on Children, which again set targets, which was really important because this was something that could be followed. And then in the early decade of 2000, in order to move beyond kind of boutique projects and to try to scale up and have sustained government action, there was pressure to provide improved evidence to countries from low and middle income countries about the interventions that had been recommended. So there was again a joint technical report series published on preventing HIV, which was a systematic review. It came out with its steady, ready, and go recommendations that were based on a very careful systematic review of the evidence, which had increased from low and middle income countries only, and introduced an interesting notion of the threshold of evidence that was going to be needed to recommend widespread implementation. So those interventions which got go were the ones, including sexuality education, by the way, were the ones that were recommended highly. This also marked the beginning of a more systematic approach to making recommendations at WHO, and which is across WHO from the early 2000s, But there were notable examples at this time where in 2012, on the guidelines on preventing early pregnancy and poor reproductive outcomes, and then also guidelines on HIV testing and counseling and care for adolescents living with HIV. So just to summarize then, how many years is that? That's about 50 years, I think. There really has been incredible progress through the decades, building on international commitments and a lot of solid work that then has been analyzed and codified. And there's been constant attention throughout, I hope you've noticed, between health and development, the critical role played by young people and the necessity of it, the importance of addressing the context and structural interventions, as well as interventions at the individual level, and for intersectoral action. Still, there's barriers. And so now I'd just like to quote from the words of Calistio from Fiji, who was part of a paper that was published to celebrate 25 years after ICPD last year in the Journal of Adolescent Health. He was one of the co-authors, and he talked about barriers, legal barriers that require for consent from parents and spouses to access services, social barriers such as stigma about having sex before marriage and pressure to prove our fertility after marriage, service delivery barriers such as cost, poor quality, and health worker bias. And underpinning these issues is entrenched gender inequality. Additionally, many adults still have difficulty acknowledging us as sexual beings and view our sexuality as a problem or something that has to be controlled. These are especially true for those of us who are LGBTQIA and those of us with disabilities. And so now, just at the end of this, I want to I'll let the video introduce itself on the health of the world's adolescents. So hand over to the video. Thank you. I hope it works.
A sense of urgency is driving action to make a real difference to the well-being of adolescents. We have the evidence and are devoting attention to programs in countries to address their health needs. Contrary to popular belief, we now know that there is a significant burden of disease during the adolescent years. We also know that the reward-seeking regions of the young brain develop before those responsible for planning and emotional control. Such research tells us more about why and how interventions should be designed for adolescents. Risk-related behaviours that begin during adolescence have profound consequences for health during adolescence, as well as long-term well-being. More systematic focus on adolescence is required in all aspects of health system strengthening as we move towards universal health coverage. Policies promoting the health of whole populations need to consider adolescents specifically. The health, development and rights of adolescents can only be fully promoted through collaboration among various sectors. Health for the World's Adolescents brings together the work across the World Health Organization that has implications for adolescent health. In the second decade of the new millennium, we have many opportunities to improve health of those in their second decade of life.
Thank you so much for sharing that video. Jane, I will hand it back to you unless you're ready to start taking some questions.
So only just to say that, in 2014, there was another recommendation or resolution at the World Health Assembly about adolescents. And that led to the development of another tool that is a specifically kind of implementation tool called AHA, which is the Accelerated Action for the Health of Adolescents. And we were hoping that Valentina Baltag, who was involved in this, could talk about that a little bit more. But then also to say, since then, there's been important developments in terms of school health, development of school health guidelines, continuing development of HIV guidelines, and review of the adolescent sexual and reproductive health guidelines is going on. And I think I'll stop at that. I'm happy to answer any questions.
Great. Well, thank you so much, Jane. That was a really, really great overview. And for the purposes of our Connecting Conversations series, it's really helpful to have this historical perspective. I think we can now have a better understanding where we come from as a field, where we are today, and it really helps us set the stage and plan more effective programs. So for the question and answer session, I thought we could turn on our videos, Jane, if you're able to do that.
Yeah.
So, hi everyone. For those of you who missed the beginning, I'm Sarah Harlan. I'm the partnerships team lead with Knowledge Success Project, and we'll see if Jane can turn on her video as well.
It says the host has stopped it.
Oh, okay.
I'm blocked.
We can, let's see. I think I'm one of the hosts. I can turn the...
Lovely to see some colleagues among the chats. I saw you entering. Hello all.
Okay, so I might need to ask for my colleagues to help turn Jane's video on because I was not able to do that. So while we get that going, I will just get us started with some questions, and I will also encourage all of the participants to write questions in the chat window if you haven't already. But I just wanted to ask you, Jane, from your perspective, having been an expert in this field and having gone through all of these different milestones in adolescent reproductive health, what is the most significant milestone in your opinion in the past 35 or 50 years that you have seen, just from your perspective?
Well, just to say I'm old, but not quite as old. I've been involved in for 50 years.
Right, but for over your career.
So I think it was probably at the 1989 World Health, the involvement of young people at the World Health Organization, the assembly. One, because also the way in which we introduced the sessions technically was through a series of role plays. And so we had a good maybe 25 young people from all over the world who had not met before. And we worked with them, and they created, and we helped them create role plays to introduce some of the issues that they were facing. And at first that was difficult, as you might imagine, to get approved, but also it was very powerful. And as was the fact that young people, co-chaired the working groups. Mm-hmm. So many of the issues that were raised still plague us a little bit. Mm-hmm. But it certainly stimulated, I know that in the region of the Americas, it stimulated action at country level in ministries of health. And that still, I think, is probably the region that's got the most substantive kinds of programs that are going. So I guess if I had to name one, and then of course the international ones, some of the MDGs, Cairo, there was a group of young people at Cairo too, not in the sessions, I can say, but who were very powerful in putting their opinions forward. So
That's great. So in light of this, and young people increasingly being at the table and being invited to the table, being engaged, what do you think the biggest challenge in adolescent reproductive health will be over the next 30 years? So just kind of looking at where we are today and thinking ahead.
program monitoring in countries, and having the capacity to be able to show results, monitor results, and so that governments invest in them.
Mm-hmm.
I mean, measurement's always been an issue. It continues to be, but I'd say I think that would, and that's, for sexual and reproductive health, we're better armed in that area because of the work that has been, going on for the past 20 years,
Yeah.
and DHS and etc. And many, many countries now, I think the Philippines, India, China, many Latin American countries, Egypt, also, has good systems that are starting to be in place. And so, but it's not at program level. They're more talking about health problems and determinants as opposed to actually measuring program processes and impacts.
Yeah, that's helpful. So for all of our monitoring and evaluation colleagues on the phone, please take note of that.
Yeah, there's a future for you.
Yeah. And so in your opinion, why do you think we continue to face barriers to young people's participation in programs and policies? I mean, it seems like over the last few decades, young people have been increasingly invited to the table, increasingly participating, but why do you think those barriers still exist?
That's a good question. I guess, so this is a personal opinion. Partially is that, because of the young people's participation, from the outset, was considered really, really important. And so, and many of the young people who participate, of course, are privileged young people. That's changing, but they're mostly kind of privileged young people. They're not part of systems. And so, and the people who have to take action and live with the action are people in different sectoral organizations and things like. So even in youth organizations, they're often older people, and young people move on. So it's and of course some young people have made a profession out of working in adolescent health in other areas, and they learn an awful lot as well. So I think the fact that it's not systematized, it's increasingly systematized. One of the things that IPPF did in the early 80s, Pram Senanayake, when she was a program director, she was the one who pushed for the attention of young people as part of the board. And so now I think in all of their regional activities, they have to have young people involved. So they have to systematically. Similarly, the World Scout Organization.
Systématique des jeunes qui participent. Cela a été également fait par un grand nombre de mouvements dès le début qui intègrent les jeunes dans les systèmes pour qu'ils puissent bénéficier d'un soutien pour apprendre les programmes. Ils ont besoin de parler.
Old people. There has to be some meeting, like there does in any negotiation, some meeting in the middle. So I guess, that would be my best guess.
Yeah, that makes absolute sense. I think it sounds like it needs to be integrated into the system.
So just one thing I want to say about that, of course, was work that we did and was asked for early on in 1989. And our friend Kate Lane, in fact, provided inputs from something that she was working on in the West African Adolescent Initiative, I think it was called. So she was actually starting to monitor and measure youth involvement in programs. And so, and I remember that because we, were able, of course, I had met Kate. We were able to put that as part of a publication. So again, measuring their involvement is important as well.
That's great. Yeah. And Kate is one of the organizers of this, as you know, and she's, she's on leave this week. Otherwise she would be talking to you now, but that's great. A little shout out for Kate. So before we get to the questions from the chat from the participants, I wanted to just share the results from the poll.
Okay.
And, so the first question was regularly WHO publishes reports, and which year was the first report series document related to adolescent reproductive health? And so 1989 was the most popular answer. And
Yeah.
then if I can see the second one, I don't know why it's not
I can see it.
expanding. Okay. So for the second one, what is the most persistent barrier to systematic and sustained attention to adolescent reproductive health in countries? So it looks like funding was the most commonly chosen answer.
Although interestingly, just to make a comment, and this is a bit of a cheat on my side, is of course they're all barriers.
Right. Yeah.
So this is a good measure of people's opinions, and you can see it's just they're pretty evenly distributed.
Yeah.
Yeah.
Yeah. So thanks to those of you who filled out the poll. I'll stop sharing that now. And we are getting quite a few questions in the chat window, so I'll start looking at some of those now. So this is an interesting question for you, Jane. Someone is asking, I would like to understand why the low involvement why is there a low involvement in other areas of adolescent health? And they're saying in our countries where we talk about adolescent health, we only think of reproductive health. So I think their question is, why is this not carrying over to maybe other areas of health? I don't know what exactly they had in mind, but I think it's a really interesting question.
Yeah, so one of the early points that was demonstrated by research, I think it was first by Richard Jesser, and he was kind of famous for work that he did looking at risk and protective factors, and he did that in many countries, and as determinants for a whole range of health problems. And that really led the way to looking at the commonality of determinants for a range of health problems. So alcohol use, other drug use, mental health, sexual and reproductive health, also violence, all those things. And that, again, was a key message that we still try to emphasize and try to look at. I think, so, and they're related, obviously. I think probably it has to do more with the fact that in the MDGs in the early 2000s, the focus was really on, in terms of health, many health issues, but in particular HIV and maternal health, so in pregnancy, obviously. So I think that really led the way, and that led to much more country programming and strategy development, etc. And I think, so that would be one reason. I think that the other reason is that the public health world tends to kind of think vertically. Problem definition is about health outcomes. Advocacy is much clearer when you're talking about, if you do this, this is the cause of this health problem, and if you do this, you can solve this health problem. And so the integration of health problems and trying to deal with several health problems at the same time is more complicated, and ministries of health are not set up that way. WHO isn't set up that way. And it's important, I think, that countries are able to kind of deal with it all is too overwhelming. So that would be the other thing I'd say, is a starting point. And began because adolescent sexual and reproductive health and puberty and all the issues to do with that, which also link into some really important lifestyle issues, and mental health issues, I guess, in particular. Dealing with those kinds of things is a starting point. So, in some ways, you have to start with that.
Yeah, I think that makes a lot of sense. And, as much as adolescents and youth themselves, and as we see things as being interconnected, that's not always how these systems work. And so, I think that's a really important point. Great. So there are, some questions coming in about kind of how to make this work at the specific country level based on some of what our participants are experiencing. So one question was, it's difficult to talk to the Indian government about adolescent health. It's neglected. Advocacy has not been able to convince them. Can you suggest some ways in which we can move forward with getting government support to expand implementation in country?
Well, I mean, India, in fact, has been more successful than others, but the challenges are huge. And, India now has, from my knowledge, has a huge number of technical and implementation partners. But of course, in terms of health problems and social problems, India has a large number of them as well, just by the you know, the pure size of the country and the diversity of the country. It's also a federation, I believe. So then, you know, then there's dealing with things at different levels. So I'm sorry to say, build on what you've got. You've got some fabulous resources. And the country has some good strategies, has excellent technical resources, and many issues, not the least at the moment, of course, is COVID.
Yeah, that's definitely true. And I would say that's across the board for some of the other folks who wrote in. We had somebody from Uganda saying implementation is still poor in rural areas, and that in the Philippines they have policies, but access to programs is a challenge. So yeah, so I don't know if you had specific comments about those countries, or if, you know, sort of some of your India advice might apply.
Yeah, I think it would. I mean, again, but Uganda and the Philippines both have got sound policies. A recent example that I'm aware of from Uganda, which has really been impressive, is a report that I had the good fortune to read, that was looking at kind of reasons for vulnerability of adolescent girls, that was done by Macquarie University. Unfortunately, it's not published. Anyways, it's absolutely fabulous. The work that has went into looking at vulnerability at the individual level, the household level, and the community level, and how that contributed to HIV and unwanted, unintended pregnancies as well. And Uganda's also features, by work I know of, the program monitoring that they do about health service delivery to adolescents across the country. So, you know, I mean, there's been huge change in the capacity of countries, and the resources is not quite enough, but all of you can do more.
Yeah. And so as a follow-up to that, we had a question: what have you seen as the most compelling argument to governments?
I mean, I think the compelling argument has, and this is where this is very time sensitive, because I think it has to do with the demographic dividend. And the fact that young people are creating, they are the future, they're creating it, and they have to deal with the problems that their parents and grandparents have created. And there's a large number of them. And so, and also, of course, because of the energy and the sometimes lack of tolerance, impatience of youth, they want action now. And so, of course, that makes adults very fearful, makes political parties very fearful also. So, I mean, I'd say that's the numbers. So we've got to make more progress while there's a huge numbers of them.
Great. Yeah. Thank you. Thank you for those thoughtful answers. I think those will be really helpful to the folks that were asking about that. So we've actually had several questions come in about monitoring, and it might be because of your comments earlier about measurement and monitoring being so important. So this first question is: the challenge of measurement and metrics for successful adolescent reproductive health programs is still a very persistent concern, despite efforts and new design approaches that attempt to improve adolescent reproductive health, especially in low resource settings. So from your vast experience, what kinds of best practices would a program consider when it comes to measuring success?
The first obvious one is age and sex disaggregation of data. And even often, if that is collected at a service delivery level, it doesn't it gets aggregated as it goes up. So it really is then trying to convince, you know, the national government and state or provincial governments to allow the data to remain age specific and sex specific. So that's one thing, and then also the drive to have common indicators. And the group that was mentioned, GAMA, the Global Accelerated Action for Measurement of Adolescence, is something that WHO started 2 years ago in partnership with many UN agencies, including UNICEF and UNFPA. There's 17 old experts and there's 4 young experts on it. And so, and that's, we're starting out with the indicator issue, you know, in terms of, you know, we started with, you know, 400 indicators, and we're trying to whittle it down because of course that's completely unmanageable, to make recommendations on indicators to use. You know, unfortunately, from my perspective, most of those indicators are, you know, output indicators or health impact indicators, as opposed to program monitoring indicators, which is going to be more difficult to standardize. And that, but at a country level, they have to be the same in terms of being able to see the progress of programs. Hope that's helpful.
Yeah, I think that's a great answer. And actually, a couple of other people wrote asking if there were specific tools or specific data or indicators that you would recommend. So I guess you already sort of covered that, but
so take a look at there are some, and WHO has some, and again, but what we're trying to do in this committee is to try to put them together, so that we're now sending out these indicators. We've gone through this process that's lasted 2 years, this process of coming up with a shorter list of indicators, and we're now sending them out for consultation. There will be public consultation on them as well. We're sending out for stakeholder consultation next week, actually. But you can take a look at some of the work on, it's called GAMMA, I think. So the Global Accelerated Action for Measurement of Adolescence on WHO website. There is a site there, and I should know what exactly is on it, but I haven't seen it lately. But there will be some technical things, and that will be the place where there'll be consultation too.
Great. Okay. Yeah, that's really helpful.
And of course, in sexual and reproductive health, there's been a lot of really good work done on that, and is being used in countries. So you know, work by Johns Hopkins, by no, my brain is leaking on that one, but there's been some good work, and it really has influenced collection of data in countries.
Great. Okay. Yeah. Thank you. That's great. And have you seen any successful approaches in actually engaging youth in monitoring, evaluation, and learning activities?
I'm going to have to give that one a thought. I don't know. I can't, off the top of my head, I can't think of one, but good question.
Yeah.
Yeah.
Well, if you do think of any, just you know, let us know, and we can send them out along with the notes for the session.
Yeah.
Great. So thanks to all the participants for those great questions about monitoring. There's also some question, a question that came in about meaningful youth engagement, which sort of relates to the last question. Do you think it will be more feasible for adolescents to be directly engaged when designing adolescent projects and in the project cycle? And which stage is more feasible to engage them?
I think it depends on the activities and the level. Certainly at community level. You know, many of the programs that are going on, well-funded programs, the DREAMS, PEPFAR-funded programs, plus the programs that are being now funded in African countries from the Global Fund. So although there's a focus on HIV, they're also dealing with unintended pregnancy. Many of those programs have young people as they're delivering the programs, in fact. They're peer programs, not necessarily peer education, because the young people are playing a whole variety of roles. So young people, certainly in terms of advocacy, have been very, very important across the board, you know, in terms of adolescent sexual and reproductive health, in terms of adolescents and HIV, adolescents living with HIV, incredibly important. And that's been important just to make the case, but then also that has influenced program design. So.
Great. And can you say anything about incorporating adolescents into maternal and child health, or, RM and CH programs? Is there any evidence of that? Is there strengths or weaknesses in doing that?
Yeah, so I don't have that much experience with that. I think, in some instances, some of the things that needs to be done to improve maternal health for young mothers is not different. They're not different interventions. The delivery is different. So as I said, I haven't looked at those many kinds of they were trying to deal with the whole package of issues, populations. I would say that one of the defaults, though, has been that the adolescent piece just talks about young people's participation and doesn't talk about anything else. And so, and of course, that's important, but it's not the only thing. And so then if you're not, in terms of thinking about adolescent health issues and how they need to be delivered differently to adolescents at different ages and of different vulnerabilities, because that's, of course, the other issue, in school versus out of school, adolescents who are stigmatized because of their sexual and gender identities, because of disabilities, because of ethnicities, those are particularly vulnerable, migrants, etc. All of those, of course, the delivery strategies have to be different. And of course, that's the same for adults and for children, but in adolescents, I think, in particular, because there's so much developmental change going over those 10, 15 years. I mean, there is in childhood as well, but children are still most often kind of the responsibility of their parents, and that handover, of course, becomes more evident during adolescence. And they're still vulnerable, even though, of course, they're on their way to adulthood. They don't have the experience of adults to be able to negotiate systems. So anyway, those are some comments, less evidence-based, I'm afraid, because I haven't really looked at many of the strategies in countries.
No, I think that's great. I mean, you have so much experience in this. So I think just hearing your perspective and
off the cuff.
Exactly. I think that's exactly what we're looking for.
Yeah. Great.
So there's one other question about integration. So what have decision makers, funders, and implementers resolved to increase information, influence decision making, and health service delivery designed to meet their specific needs? And they mentioned things like menstrual hygiene management, contraceptive and condom use, things that are often taboos in many countries and in many settings. I would say, including the United States often. So what have you seen decision makers or funders do around these sorts of topics?
Well, advocacy is critical, and to get it on the agenda. And for advocacy, you need, a range of peoples with different voices with the same messages. So, to be able to articulate the need slightly differently to slightly different, stakeholders and numbers, being able to say why it's important. Interestingly, I've been working on something that's dealing kind of with vulnerability and having some difficulty with the concept of vulnerability with respect to unintended pregnancy, and I'm not sure why. So some of the people I've been talking to have been saying, well, maybe it's because it's considered to be universal. It's a universal right. Yeah. Of course, it's the vulnerability issue shouldn't be important. I thought, okay, maybe because people don't want to target different populations differently because of that's inherently a political question. Maybe because they're not necessarily looking at, so one of the questions I had and started trying to see whether that made a difference is, do countries when they're thinking about contraceptive availability, supply in countries, and when they're planning that, do they think about that? Because of course that's an issue in terms of access to all people in most countries. Do they think specifically about adolescents and the contraceptive methods that adolescents tend to use more than other populations? Anyway, I haven't found an answer to that. I mean, I'm trying to think about how, are there ways that, at a big level, reproductive health, national programming, how are they viewing adolescents differently? And what are they? So, and I think that one of the things too, I guess, that I will have learned after trying to deal with an awful lot, too many things, too many subjects and too many health topics is really the importance of trying to do a few things. Have a long list, maybe. Don't tell the long list to everybody because they'll just get overwhelmed. And start to try to do one or two things well, kind of at the beginning. And try to be able to show the results again, too.
Yeah, I think that's really great advice, because I think a lot of times we feel so overwhelmed with all of the different challenges and barriers and all of the different topics that we want to cover. So, figuring a place out to start, I think, is really important. That's great. So just a couple more questions before we wrap up. We've gotten a couple of questions around social behavior change. So what are the best SBC strategies to integrate family planning uptake with skill acquisition for adolescents? And then related to that, how can we also best include religious leaders? So kind of thinking about, structures and communities a little bit.
So I'm not a social and behavioral communication person. I have no expertise in that at all. Although great respect for its importance. And I think they would say that how important it is at different levels to different audiences, and how you have to modulate the messages to different audiences, and then who's speaking, what's the voice, and that range of voices, again, I think is important. And again, and that relates, I think, to the next question in terms of religious and traditional leaders. One of the things, again, about adolescence is that there is this sense of, people want their children and adolescents to be healthy. They're counting on it. So like there is this absolutely visceral desire for healthy development of the children and adolescents. And, religious and traditional leaders in some ways embody that, the hope for human and social development in some ways the most. And so tapping into that.
Et le développement des êtres humains. Mais il faut utiliser ce désir. Il faut regarder comment il parle de la sexualité des jeunes. C'est une question universelle, tout le monde le sait, mais c'est aussi...
Adults fearful of adolescents are sometimes behaviors they've not been able to manage themselves as adults. That deals with violence, for example. They have or things that they see manifest in their countries that they can't deal with, they can't understand, and they can't deal with it. So those kinds of one-to-one kinds of conversations, and how those, the discussion about storytelling that we were having earlier, Sarah, is very critical, and those things, I think, can influence those leaders, and of course getting these people on board is critically important in all countries.
Yeah,
even the right wing seemingly enemies.
So
gotta win them over.
Thank you so much for that. That was really helpful. So we're just about to wrap up. We just have a minute left, but I just wanted to address some additional questions that have come in. I mean, a lot of us that are on this call, or a lot of participants on this call, maybe weren't alive when the timeline started. Might be feeling a little bit worried, thinking that we have made limited progress, and that we're sort of in defensive mode or protection mode in the current state. So what can we do to advance things now? Is there one thing that you would say, just, that we can do now to kind of feel hopeful?
So there's been huge progress. I mean, I can attest to that. You know, I have living memories of many of these things. And many of the arguments are still critical and are reoccurring, you know, so get used to hearing yourself say the same things over and over. Build on success. Be quite aware, as I said, of what your enemies are saying, you know, the forces that are against you. Be quite aware of what they are and why, and try to understand them, not just dismiss them. But build on the success. And, you know, most of the countries that I'm aware of, you know, there are incredible successes that have gone on. And, you know, many of you, the people who are listening to this, are contributing to it on a daily basis. So don't give up. I mean, it's absolutely, you know, we just cannot give up. We've got more to do.
Well, I think that's a great note to end on, a very hopeful note. Thank you so much for taking us through the history of adolescent reproductive health over the last several decades, and, you know, sharing all of your wonderful insights and experience with us.
Pleased to be here.
Thank you so much, Jane. And thanks everybody for the engaged and thoughtful chat box discussion and all the wonderful questions. We were able to get through most of them, but not all. But thanks again for all of the great participation. Just a reminder that we will be posting and sending out a recording of today's webinar, and please join us for the next webinar in the series at the same time on August 12th. And the topic for that webinar is how social norms and cultural practices affect and influence adolescent and youth reproductive health. So that should be a really interesting discussion as well. And if you are not already following Family Planning 2020 and Knowledge Success on social media, please do so you can get all the latest updates. And I think that is it. We are a couple minutes over time, so thanks to those of you for staying with us. And thanks again, Jane. It's been really, really nice
Thanks
talking
for the
with
invite.
you.
Great to be here. Thank you.
And thanks, everyone. We'll see you next time.
Yes, hope so.